Hello, everybody. It's my pleasure to talk to you. This is Dr. Sunetra mondal, consultant endocrinologist in Health World Hospital, Durgapur. So I'll be talking about a very commonly encountered case in diabetes clinics across the country. So I start with the story of a 45-year-old man with newly diagnosed type 2 diabetes. He was diagnosed around 6 months back. He had multiple risk factors, including obesity, hypertension, and dyslipidemia. So 6 months back, he was started on metformin along with lifestyle advices. So recently, he has visited again as a part of his routine diabetes checkup. And on investigation, he was found to be having HbA1c as high as 8.5%, along with LDL cholesterol of 80, HDL cholesterol of 38, and triglycerides of 200, all of which were a bit above target. His current medications included 1 gram twice daily metformin, along with antihypertensives, lisinopril and metoprolol, and statins. So on physical examination, he was found to be having a BMI of 31. He did not quite lose much of weight over the past 6 months with metformin and lifestyle alone. His blood pressure was well controlled. So what should be the next best treatment for him? Of course, nothing is absolutely wrong or right in the management of type 2 diabetes mellitus, but of course, something is better than the other. So now we have ample evidence to show that early and intensive glycemic control achievement can reduce the risk of long-term microvascular and macrovascular complications in type 2 diabetes mellitus. This we know way back from the UK-PDS trial, which also demonstrated a legacy effect, meaning that the benefits of early intensive glycemic optimization can persist years after the intensive therapy. The HbA1c difference between intensive and conventional arms were no longer apparent. So the benefit persists for several years after the glycemic optimization. So for patients like this, in whom metformin alone is not helping, or possibly even in other patients where metformin is not the first-line suitable agent, and possibly also in patients with high cardiovascular risk factors, we should initiate a combination therapy of other agents might be necessary to achieve the target HbA1c as early as possible. Several guidelines focus on intensification of a monotherapy dose up titration till the target HbA1c is reached. But for the Indian settings and for those with high cardiovascular or renal risk factors, an early combination therapy would possibly be more appropriate. And we also have data now from meta-analysis to demonstrate that early use of combination therapy significantly increases the likelihood of achieving glycemic target of HbA1c less than 7% compared with up titration of other drug monotherapy. And also, some of the guidelines focus on combination therapy when the HbA1c is more than 1.5% above the target. So if you're talking about combination therapy, nothing can be better than combining one of the safest agent, that is a gliptin, a DPP-4 inhibitor, along with one of the most effective agent, that is one SGLT2 inhibitor. So a combination of these two in a patient on metformin would possibly the most suitable second-line treatment, and in patients with high risk for cardiovascular and renal disease, possibly one of the best first-line treatment as well. So if you're talking about empagliflozin as the SGLT2 inhibitor and linagliptin as the DPP-4 inhibitor in combination, these two have complementary mechanisms of action. So by their pleiotropic mechanisms, they can address many of the pathogenetic arms of the ominous octet of diabetes mellitus. Also, the SGLT2 inhibitor can take care of the cardiovascular risk and renal risk, particularly for patients who are at high risk, or for patients who have an established heart failure or an established kidney disease, and with no increased risk arising from the gliptins, because we know they are one of the safest agents to use, except for some rare contraindications. And HbA1c decrease with EMPA-LINA combination has been shown to be as much as 1.81% at 24 weeks in patients who were already on metformin. And the benefits were maintained till week 52 and were apparent as early as 12 weeks after therapy. And also, a higher percentage of patients could achieve the HbA1c target of less than 7% when they were given this combination as compared to others. And of course, with a better effect on the lipid profile, on the blood pressure, on the body weight, and no additional side effects. And some studies have actually shown that when we are combining one SGLT2 inhibitor with a DPP4 inhibitor, they can have a lesser risk of the genital mycotic infections, which we are very much concerned about when we are giving SGLT2 inhibitors. This is not only because of better glucose control, but also some other mechanisms like effects on fungal metabolism, vaginal pH, etc. Of course, they remain to be investigated further. So in summary, for this patient and many other patients like this who are obese, who are having multiple risk factors for cardiovascular and renal disease, or who are having established cardiovascular disease or renal disease or heart failure, and possibly even in patients without any of the risk factors, this combination of a gliptin along with an SGLT2 inhibitors, as of now, the most effective and most commonly used agent being empagliflozin linagliptin combination. So this can provide robust HbA1c reduction, better control of the other risk factors like lipid profile, blood pressure, and body weight, and provide a long-term protection from cardiovascular and renal risk. This is in addition to the glycemic control they are giving with no added risk of hypoglycemia, of weight gain, or any other things. Thank you so much for your patient hearing.